delighted to welcome our second speaker, Anne Cronin. So Anne is a second-year PhD student in food medicine. She's supervised by Professor Anne McFarlane and Dr. Patrick O'Donnell in the school, and also by Dr. Mary Phelan, who's in DCU. She works with the HSE as well and the migrant health team in Dublin, and she also is research assistant on the refugee and migrant health partnership between the participatory health research unit in UL and the Department of Health. So we're delighted to welcome Anne here today.
Thank you, Walish, and thanks everybody. I'm really delighted to have the opportunity, I suppose, to present our work here today with Knowledge with Impact. And I guess whilst it is very different from previous project that you spoke about, it's still that thread of communication and, I suppose, group of people that might have difficulty accessing services. So it's a study that we have all but completed, or we're nearing completion, and just, I suppose, all of the collaborators on this project are listed here, including Doris and Cordia, HSE, DCU, and just to recognise the funding that we received from UPI Ignite. So what I want to talk to you today about is Ukrainian refugee interpreters working in bespoke primary care clinics, a case study of Irish policy in action. And as Walish said, I currently work in the HSE, in Dublin, and migrant health team, working mostly with applicants for international protection, beneficiaries of temporary protection. But before that, I worked in the not-for-profit, in the NGO sector for well in excess of 20 years. And I suppose the space I worked in was inclusion health, so working largely with marginalised populations that for the most part were homeless, were entrenched in long-term homelessness. And we provided accommodation supports and health care supports very often for people struggling with addiction, mental health issues, disabilities. And so fundamentally, I suppose the core part of that work was the recognition that healthcare is a human right for everybody. And refugees and migrants are no different. Refugees and migrants have a human right to accessible, affordable, safe and equitable health. And I suppose a lot of the work that I'm doing and we're doing is around making primary care services adaptable and accessible to patients that are increasingly linguistically and culturally diverse. And so I suppose the focus of my work and this project in particular is on the cross-cultural consultation. So what happens when a doctor or a healthcare worker meets a patient and they do not share the same culture or the same language? We know, and all of the evidence tells us, that best practice is accredited trained interpreters. That's the most effective response in terms of optimizing communication, and that when we don't have access to that, we see poor care outcomes. And the WHO tell us that refugee and migrant patients experience patient-centered care when, despite these cultural differences, health professionals take the time to explain what's happening to the patient, include culturally relevant references, and take on board the needs of the patients and involve them in the decision making. So I guess very much influenced by the work that I had done previously, I was very happy and am very happy to be involved with the Participatory Health Research Unit at the University of Limerick. And it made a lot of sense to me that any of the work that I was doing, the PhD, was for using a participatory health research was steeped in that paradigm. And so the work that I'm doing is really about doing research with people rather than on people. So rooted in Paulo Freire, emancipatory traditions to promote social justice and to strengthen knowledge translation. So again, based on the values of mutual respect, equity and inclusion, and a lot of the research methodologies that I use and researchers in the unit use inherently really pay attention to the power asymmetries. So what we're doing a lot of the time is trying to create that safe space where interested and impacted partners, so refugees and migrants themselves, or advocacy bodies that work with them, as well as policymakers and health managers, come together in a respectful manner, respecting the diversity of views and experiences, learning from each other's perspectives. And so in my research and as part of the study, the key partners really are the NGOs and the refugee advocacy bodies. And I suppose I worked with Doris and Cordia on this project. And so this, I suppose this case study that I'm going to present is one in a program of case studies that started long before before I became involved, and led very much by Professor Anne McFarlane over 20 years ago, I suppose, looking at what was happening in these consultations, you know, what were the dynamics. And so one of the first studies was over 20 years ago now, in the west of Ireland, looking at the dynamics when GPs and patients meet. You know, the reliance, so the findings there were a reliance on friends and family and ad hoc measures, and basically the patient being very dissatisfied with this kind of communication. The next study looked at more national perspectives, looking at what these ad hoc supports, as they're called, versus formal support. So whilst formal interpreters were seen as the ideal, they were rarely being used. The next study again looked at the systemic issues. So what are the barriers? So the findings there again that we saw lack of policy, lack of confidence, lack of GP skills, and this idea that there were, you know, that it was time consuming to have an interpreter in the room. That was followed up by a 5-country-wide EU project called Restore that looked at the guidelines and the training and possible implementation in these countries. So again, looking at the barriers to implementing interpreters in primary care, but also participatory methodologies to address these gaps in a more meaningful way with healthcare workers. And again, that speeds us up to right now. The project that I'm doing, which was, I suppose, born out of an opportunity in terms of the Irish policy response to the number of Ukrainians that came into the country in February 2022, and the Irish policy response being the implementation of interpreters in primary care clinics. And so that's just a snapshot of the case studies today. So I suppose what we do know is that there are significant health risks when an interpreter is not used and when there's a reliance on ad hoc supports, but there are real world challenges in implementing trained interpreters. And so, like I said, we were very interested in this Irish government policy response to the Ukrainian crisis. And I suppose the context there is that there, in lots of these areas, new bespoke primary care clinics were stepped up because what was there was at capacity. And so we looked at two main sites, a large accommodation centre that had its own GP clinic in that accommodation centre that was working 5 days out of 7. And then we also looked at a primary care clinic that was set up that covered over 30 accommodation centres where Ukrainians were living. And so in those clinics, we wanted to look at how well is this policy response working, and what can we learn from it. And I suppose just to say as well that interpreters were available in these primary care clinics, and there were usually all of the people that we met were displaced Ukrainian people themselves that were multilingual, spoke English, Ukrainian and Russian, and were hired by the agency as interpreters. So very briefly, our research question was to look at the impact of this Irish policy response on communication in interpreted consultations between a Ukrainian patient and a GP. The aim was to examine this communication, and our objective overall was to look at and to document the dynamics and interaction of the interpretive consultation, to also capture the perceptions that of the participants, so how the GP and the interpreter and the patient felt about the interaction, and then to synthesize those findings. So our methodology, again, it's a participatory health research study. So we, our collaborators are from academia, both the University of Limerick and DCU, the HSE, National Social Inclusion Office, and our community partners, again, Doris and Court. And just to say that our community partners came with me into the clinics when we conducted our field work, and we wouldn't be able to do that without their involvement. And so it's a mixed method study based on 3 components. We conducted discourse analysis of our recorded consultations, of which we had 21. We then did an interview study with the stakeholders, the participants, so that's the GPs, the patients, the interpreters, to get their perceptions of the consultations, and then we did a comparative qualitative analysis. So I suppose we use discourse analysis, and the framing of our analysis was on the communication and the interaction between interpreters and patients, and interpreters and GPs. And so we wanted to look at how language is being used in that context, aware that it's never neutral, and what can we take, what is the meaning of I suppose, the discourse and the communicative event between interpreters and patients, interpreters and GPs. Like I said, we did 21 recordings to analyse, and discourse analysis allowed us to really take a deep dive into the work the interpreter is doing in these consultations, and for the first time to create a taxonomy that really demonstrates the wide scope of work the interpreter is doing. Also, how the interpreter enacts that role. Is it, I suppose, what we would typically think of, that kind of normative idea where it's that idea of, interpreting and translating word for word, or is there something else going on? Is there other activities that the interpreter is doing? How do participants, or how do the patients and the GPs respond to that? And what layers of meaning can we ascribe to that? And then we did our qualitative interviews, and we had 3 GPs and 4 interpreters available for interview. So in terms of results, then I suppose what became clear very quickly is that, context is really, really unique here. Like I said, the context is the Ukrainian war, and just by way of, I suppose, demonstrating it here today, we've color-coded it because there is a lot of intersubjectivity here. There's a lot of shared meaning, shared values, and so the interpreter shares quite a lot of characteristics with the patient, but also with the GP. So you can see, I suppose, what we've coded in purple between the GP and the interpreter. You can see that there's a lot of, like I said, shared characteristics, especially in terms of how they came to the work, the opportunity that was presented, whether they were self-selected or volunteered by others. It is paid work, but their journey to the work is kind of similar. Limited training, both of the GP and the interpreter, in terms of doing this work. And then also, I suppose, this belonging to an interdisciplinary team. They both talked about that, and the idea that whilst they are employed by different agencies, there's very much this idea we work for the same team in this primary care clinic. So too, I suppose, the relationship between the interpreter and the patient, they share a lot of characteristics in that they're similarly, they're refugees, they're coming from Ukraine, having experienced many of the same things in terms of displacement, trauma, uncertainty around their accommodation here in Ireland. Again, very often they could be single parents, parenting children and with grandparents. And again, I suppose, grappling with that idea of transiency in terms of their accommodation. And I should also say that the wider context here is that in Ireland we are operating, or interpreters do operate, in the absence of regulation and code of standards about this kind of work. And so there is limited training available and provided the interpreters that do this work. Secondly, I suppose we saw, and this is just a snap, it's just a snippet from one of the transcripts, we saw much evidence of where the GPs and the interpreters collaborate. I suppose this is a good example of that. And discourse analysis allows us, I suppose, to pick moments that aren't necessarily replicable across all of the data, but are moments of interest that tell us a story about this case study. And this is one. I suppose it's you know, it's the GP, the interpreter, and the patient. And if you can look at it, the patient has 4 different utterances in this transcript, and they're all sounds. They're not actually words. And so I suppose we saw this, and if you can imagine, we were looking at this, we were analysing this, but also listening to the audio, and it became clear that the patient and the GP are picking up on the patient confusion. And I suppose the patient uncertainty about why they're not possibly, in this case, getting an antibiotic. And so whilst it's never actually said, that the GP and the interpreter work together to resolve that until they're finally satisfied that the patient, you know, indicates that the patient has understood why, in this instance, the GP isn't giving antibiotic. And I suppose we also felt that this segment is a good example of where AI is not suitable, in that it's, I suppose the patient is speaking in sounds rather than words, and AI could never, I suppose, or at this stage I should say, AI is not able to I suppose, create meaning from something like that. So we thought it was interesting. In terms of the interpreting itself and the job of work that the interpreter does, we use what EMSO's taxonomy of renditions. And without getting too technical, I suppose the main idea is that every time a patient and a GP speaks, that's called an utterance. And then what the interpreter does with that utterance is called a rendition. So how the utterance is rendered. And I suppose what we see in the vast majority of our data is that a very close render of what the patient and the GP said. And so we're also seeing, in some instances, in 24%, that that's not the case. So I suppose we wanted to see what, in its full entirety, what the job is that the interpreter is doing. But I should say that some of the non-renditions still constitute an overall rendering of the information. So the interpreter might have asked a question that, you know, is non-render, but in the overall, I suppose, consultation did still communicate important information from the GP or the patient. Okay, so like I said, we're seeing the majority of the work that the interpreter is doing is that close rendering of each GP and patient utterance, but we're also seeing the interpreter clarify patient details further, exchange unprompted medical information, and sometimes that is jumping in with a question before the doctor or before the GP asks it, because they might be used to the GP asking that question. We see the interpreter clarify what the GP is doing or saying. We are seeing the interpreter provide information in terms of follow-up care. So sometimes that's about a medical card, a prescription, the pharmacy in Shannon or the pharmacy here or wherever it is, and more suitable pharmacies. We see alignment with GPs or assisting the GP in terms of the work. It could be computer work, it might be clarifying something for the GP. And sometimes we see evidence in the interpreter self-correcting or checking medical terminology with the GP. And we also see, I suppose, wider scope of work within the GP clinic. So some of these interpreters are working also in terms of organising follow-up appointments, callbacks, giving results, and things like that. From the interview analysis then, we're reporting that the GPs appear to have good working relationships with the interpreters and trust that their interpreting work is up to standard. Consultations are quicker than first envisaged, so the average length of a consultation is 17 minutes. And so that sits kind of squarely in the middle, I suppose, of the guidance that these clinics have, which is between 15 and 20 minutes. Participants are reporting that it's better to Google Translate and other ad hoc measures, and many of these GPs will have used technical devices previously, like Google Translate and things, and ChatGPT. The sidebar conversations are not considered problematic, which is, I suppose, an outlier in terms of the literature would often tell us that sidebar conversations do interrupt the GP's work. In this instance, we're not seeing that, or it's certainly not being reported by the GPs. On-the-job learning is taking place routinely, and the interpreter is exposed to common issues on a very regular basis. And again, there are higher levels of intersubjectivity between the GP and the interpreter. So finally then, our case study will report on the unique context in which these clinics were set up, the interpreter's role and responsibilities both within the consultation and the broader clinical setting, the collaborative nature of the work. Participants are broadly satisfied with working together and perceive multiple benefits for the patient. Interpreter expertise, there's repeated exposure to routine medical issues. Excuse me. Interpreter's previous experience of non-medical interpreting work is evidenced. There's on-the-job learning and ongoing professional development outside of the work. So some of the interpreters talk about that. There are areas for improvement. There's a need for further training, upskilling, and a desire to professionalise the interpreter role within the health systems. That came across very strongly from the interpreters, this desire for they themselves to become more, for their role to be more professionalised. Like I said, in terms of patient-centred care, the GPs spoke about that. The side sequences, this is something that we're really interested in. And in terms of the GPs in the study, they considered it a mark of potentially the patient confidence, that it was a sign that the patient was in good form. So when the patient came in and they were having this kind of additional dialogue with the interpreter, or that they broke into that kind of chat when the GP was working on the computer, for example, or doing something like that, that really didn't bother the GPs. Like I said, it was something that they felt contributed to patient-centred care. And then finally, I suppose the value of in-person interpreters versus AI solutions. This is something we're really interested in. And we're currently conducting a scoping review on the patient safety implications of using AI in synchronous consultations with GPs. And so I suppose we found in this study that there is work that AI cannot replicate. So just finally, just to acknowledge, I suppose, my supervisory team, especially Professor Anne McFarlane, Dr. Mary Phelan, Dr. Noor Ibrahim, and then Dr. Patrick O'Donnell. The Participatory Health Research Unit, where I conduct a lot of this work, Kathleen Markey, Ailish, Helen, and other colleagues from the unit. Our community partners, like I said, I wouldn't be able to have completed the field work without them, so special thanks to Ahmed and Serge, and then Tanya and Julia from Cordia. The steering group, Aileen Kitching and Katja Kusherets, and of course the staff from the two primary care clinics, and of course the patients, the interpreters, and the GPs that engaged with the study. So thank you very much.